Hello, this is Dr. Kim Jeong-gul. Today, let's take a closer look at the analysis of the skeletal pattern. In general, when assessing skeletal pattern, many orthodontists see an anteroposterior relationship through SNA, SNB, and ANB, and vertical relationships through FMA and SNMP. When each point and line are expressed as SNA, SNB, ANB, FH, and mandibular plane, there seems to be a limit to grasping the anteroposterior state and overall outline of the maxilla and mandible. Let's look at the anteroposterior relationship APDI, the vertical relationship ODI, and the combination factor used in MEAW analysis. The abmaxillomandibular triangle is a triangle made up of the palatal plane, AB plane, and mandibular plane. The ODI made up of the AB plane and the mandibular plane. APDI made up the palatal plane and AB plane. And the CF that added the two values to understand the overall state of the skeleton. It's easy. If I review what I have studied so far, the combination factor is greater than 155. It is a high CF, a low angle type with round face. If the CF is less than 150, it is a low CF, a high angle type with long face. Measure ODI, APDI, CF using the palatal plane, AB plane, and mandibular plane. Look at APDI first, then look at CF. This patient has an APDI of 75 and CF 155 with a class 2 low angle. And this patient has an APDI of 80 and a combination factor of 155 with a class 1 low angle. In addition, this patient has an APDI of 90 and a combination factor of 155, so it can be classified as class 3. When looking at the skeletal growth pattern before and after the patient's treatment, in the case of a skeletal with vertical growth, the face will be longer, and there is a possibility of open bite. After treatment, ODI and APDI change, but the combination factor hardly changes. In the case of a skeleton that grows horizontally, the possibility of deep bite. And after treatment, the ODI and APDI may also change, but the combination factor hardly changes. If ODI 71, APDI 69, combination factor 140, ODI is normal. APDI is less than 77, so it is class 2. And CF is small, so it can be classified as class 2 high angle. Since ODI 79 is larger than 78, it tends to be deep bite. And because it is APDI 80, it is class 1. And it is combination factor 159, so it can be classified as class 1 low angle. Is it possible to change the skeleton of high angle to low angle? If there is a change, the high angle of the large frame can be changed only within the range of the high angle, and the low angle within the range of the low angle. Please understand that high-angle skeletons are difficult to change into low-angle skeletons. However, there will be exceptions if you have surgery. Let's analyze it with the patient's skeleton. APDI is 69, ODI is 71, combination factor is 140, so it is class 2 high angle. Could this patient be a class 2 low angle? Impossible. ODI 70, APDI 75, combination factor 145, class 2 high angle. ODI 75, APDI 80, combination factor 155, class 1 low angle. Looking at the patient's lateral view, class 1 low angle patient has good chin profile. But class 2 high angle patients have retrusive chin with mandible going posteriorly. Class 2 high angle patient with ODI 69, APDI 75, and combination factor 144. After treatment, the CF value is still small with ODI 65, APDI 80, combination factor 145, or 65, 70, 135. ODI 64, APDI 73, combination factor 137, class 2 open bite, that is, high angle patients. The combination factor still remained unchanged after treatment. This is a high angle patient with a combination factor of 144. You will understand that the combination factor cannot be 155 after treatment. Combination factor is 160 and the skeletal volume is sufficient. After treatment, the combination factor is almost maintained at 160. APDI 73 and ODI 76 tend to be deep bite. But they are class 2 high angle patients because the combination factor is small. There is a tendency for deep bite, but since it is a high angle patient, treatment to extrude the maxillary molars would not be desirable. After treatment, the APDI was 79 and the mandible was well anteriorly. However, the combination factor is still a similar. That is, ODI and APDI complement each other and change, but the combination factor does not change. This is to understand that the volume of the skeleton does not change significantly. This is an 11-year-old male patient. The upper jaw is protruding. ODI 87, APDI 69, combination factor 157, class 2 low angle. The growth direction of class 2 low angle means the skeleton of the possibility that the mandible can come forward. Since the patient is currently profile for protruding mouth, should I have to extract the premolar? It's a case that shouldn't be extracted. After treatment, the combination factor almost remained at 157 to 158. But ODI and APDI changed in a good way to complement each other. Let's take a look at this patient's pre-treatment, post-treatment, and post-retention profile and intraoral photos. Even after treatment with non-extraction, it turned into a good profile. What if this patient had a premolar extraction treatment? Perhaps the extraction space has opened again or the facial profile has become unaesthetic. This patient has a large overjet and features a protruding lip. ODI 75, APDI 74, CF 149, and the mandibular plane angle is 25 degrees. ODI tends to be deep bite, but the combination factor is small. ODI is large, so some doctors will try to use headgear. However, the CF is small, so if it is treated incorrectly, the mandible is possible to rotate to the backward. Backward rotation of the mandible may worsen the protruding lip. The treatment plan for this patient is to use headgear or extract premolar after observed growth changes. At first, the ODI is large, so I wear a headgear and kept his mouth shut. However, when re-examination, the lateral profile was still protruding. The skeletons are ODI 72, APDI 78, combination factor 150, CF is still small. Should I push the first molar of the maxilla further back? If you push the first molar backwards, rather the posterior area is crowded. Therefore, only the maxillary first premolar was extracted, and the excessive overjet was resolved, and the treatment was completed. After treatment, the patient became comfortable with good profile. After treatment, ODI 69.5, APDI 78.5, combination factor 148. The anteroposterior relationship has improved, but the CF has not changed much. That is, the CF before treatment was 149, the revisit was 150, and after treatment was 148. In summary, high angle type will show open bite and CF will be small. In this case, you need to extract somewhere. Low angle type is deep bite, high CF, and if possible, non-extraction should be treated. The combination factor is 157 and it is a low angle type. However, a protruding lip is observed. Would facial profile be improved if treatment with non-extraction treatment? Looking at the CF like this to analyze the volume of the skeleton. You should know that facial profile is more important. Therefore, I first look at the facial profile, and then I look at the combination factor. So, when looking at the combination factor clinically, if there is crowding in the maxillary and mandibular anterior teeth, if there is crowding in the maxillary anterior teeth, if possible, non-extraction treatment is better. And if there is crowding in the mandibular anterior teeth, the possibility of extraction even if the CF is large. Although the combination factor is large, the bite may deepen if the premolar tooth is extracted incorrectly. So care must be taken to extract the premolar of the mandible. If the maxillary anterior teeth are labiversion, consider only the maxillary premolar extraction. The combination factor is small, but non-extraction treatment can be an open bite of the anterior tooth. So you can extract somewhere. First of all, the teeth you need to consider are the third molar, maxillary second molar extraction, maxillary and mandibular second premolar extraction. Maxillary first premolar and mandibular second premolar extraction, maxillary and mandibular first premolar extraction. Thank you for watching.